So good afternoon, everyone. Thank you for coming to Medicine Grand Rounds. Unfortunately, Dr. Chopra will be coming in a little bit late, and he asked me to introduce our speaker today, Dr. Johansen. So, which we're very lucky she will be presenting the Wallstrom Lectureship. The Wallstrom Lectureship is in honor of Matt and Agneta Wallstrom, who are good friends of the renal division and actually provided a large gift for endowed chair and a lectureship that really allows to support clinical research in the division of nephrology and support inviting great speakers like today that we have Dr. Johansen. Dr. Johansen is a director of the division of nephrology at Hennepin Healthcare System. She did her undergrad at Dartmouth, a med school at Duke, internship and residency at the Mass General, and then went for fellowship at UCSF, where she pretty much went up all the ranks from assistant to full professor, and then was recruited back to Minneapolis at the Hennepin Healthcare System back in 2018, where she's the current director of the Division of Nephrology. She serves on many committees in the American Society of Nephrology and National Kidney Foundation, including the Publications Committee on the ASN, as well as the Kidney Disease Improving Global Outcomes, which is a big society in nephrology. She's part of many editorial boards, including was deputy editor for CJASN, that is one of the most read journals in nephrology. She has numerous awards, and important to kind of underline the Michael Lazarus Distinguished Award that is really being given. It's one of the highest awards given by the National Kidney Foundation. She's extremely well funded with an R1, UO1, and a K24, which speaks really to her long track record as a mentor. She has over 260 publications and is really a world expert and pretty much a national expert in the area of frailty in patients with CKD and dialysis, where she will be talking today. Thank you for your attention. Thank you, Kirsten, for coming, and we're looking forward to your talk.
Thank you for that kind introduction. And thank you all for coming today. I'm going to talk to you today about physical activity, physical function, and frailty in CKD. Some of what I'll talk about is going to relate to dialysis patients because that's the group that's been studied the most. But we will also talk about CKD, which might be more relevant to your patient populations. And we'll talk more, but most of what I say about dialysis is also relevant to CKD, I think. So going forward, I was asked to put this slide in there. Should I give you a second to scan this? I see people scanning, so okay. As you already heard, I have the honor of having been invited to give this lecture, the Wallstrom Lectureship, and it is a great honor indeed. And you all are really fortunate to have these generous folks that I also had the pleasure of meeting last night, and their support of the nephrology and hypertension division. These are my disclosures. And this is just a brief outline for today. So I'm going to spend some time just talking about physical activity, function, and frailty in patients with CKD, and then talk about exercise to address poor functioning and frailty, and then a little bit about barriers to exercise and some future directions. So I just put this in here to set the stage a little bit. And I thought I'd try to tell this a little bit, maybe as a story. So when I was a fellow, it wasn't so clear that dialysis was a wasting condition, but we were starting to get some data that it was. And so I was interested in the idea of nutritional status and how to address wasting. So we did this study to try to increase weight and improve lean body mass in patients on dialysis with an anabolic steroid. And that was actually successful, But what I learned as a part of that study sort of changed my direction off from lean body mass and nutrition more into physical function. So what we did, and also just the experience of, since it was my fellowship project, I had a small grant funding, but I was the research coordinator, and I was the person administering the questionnaires. And what they told me and what we found was just really life-changing to me. One of the things that we did, and I did have one helper in this, but we did maximal treadmill testing. We tested maximal oxygen or peak oxygen consumption. And my mentor was an endocrinologist, actually, who was studying AIDS wasting, not a nephrologist. And so we did these testing together. I would test my patients, and they would help me, and I would help test their patients. And I had never done this before. I'm a nephrologist, and I was a fellow. So I picked the healthiest dialysis patients to start with. I didn't want anyone keeling over on a treadmill. So I was studying relatively young men. And they were studying relatively young men with AIDS wasting. In any case, so these bars here are just some data that we generated from that really early study. And this yellow bar was our patients, our dialysis patients. And so this is their average age, 38 and a half years old. And this is their oxygen consumption. And this is what you would expect for patients, individuals ages 30 to 40. So they were about half. And this was not new information. I don't want you to think like we discovered this. This was actually known. It was out there in the literature. But to see it in firsthand was really something. And then also these patients were actually better. And this was in the old days when HIV wasting was such a big thing. These patients had lost more than 10% of their body weight to even qualify, and most of them considerably more than that. And they did better on these treadmill testing than our patients. So that was one stunner for me. And then the other thing that we did was administer some questionnaires, and we asked them about their physical functioning. And this is one scale that we used, which is just not a disease specific. You've probably heard of the SF-36, but the physical functioning score, which just asks them if they're limited in doing these different activities, and just comes up with a scale that's a score from 1 to 100. And so these are some data that I put together from that. So most of the data on this slide are the data from the original medical outcome study where they developed the SF-36. And so this is the normative data that they came up with for the general population, about a score of about 85. And then they also looked at various disease conditions over here, and you can kind of see what they are. But I'll point out that the brown bar is COPD patients, and this green bar is heart failure patients. And then these two bars are dialysis patients. The blue bar were the patients in my study, and the red bar were patients in another study that Peter Diorio's group had done in Ohio, where they studied about 1,000 just unselected dialysis patients. And so I found this really quite fascinating that, sorry, I got it backwards. The blue bar was his study and the red bar was mine. And so one thing I think that we found is that just selecting a group of patients who's going to come into your research lab and do walking studies and things like that already pre-selects a healthier group of patients. So our patients were considerably more limited than the general population, but they were actually a little healthier than even the general unselected nephrology population. So I was really just struck by that. And it really made me want to kind of go a little bit more in the direction of trying to figure this out. You know, we realized that dialysis patients are really deconditioned and they had really poor function. And we also did an intervention, like I said, and patients reported some improvement that we really didn't capture. And I don't know why this slide is misbehaving. But anyway, and so we wanted to kind of look in a few directions. First of all, how can we measure physical activity? You know, and is it important? And then what's going on in the muscle with these patients? And then how can we improve functioning? Those were sort of three questions that are supposed to be in the circles. On my computer monitor, they were. Sorry about that. So the activity issue really came up. We wanted to try to study, okay, why are they so bad? Why are they so low? Can we tease out what might be related to kidney disease or dialysis per se versus what might be from comorbidities or other things going on or sedentary behavior? So we set out to try to do that. And the first thing we thought was, well, let's try to see if we can get a group of controls who don't have kidney disease who are relatively sedentary. So we selected controls by first asking them if they did any kind of regular activities. And then we recruited our dialysis patients, and we tried to kind of come up with a pretty similar age distribution. And so this is a little bit backwards. And so what we found anyway was that even though these controls were recruited to be sedentary, when we used accelerometers to compare, we found a pretty big difference between the patients and the controls. So this is actually kind of a problem because to date, despite trying numerous times to find inactive controls, we never find controls who are as inactive as our dialysis patients. Dialysis patients are not walking around their houses as much as other people, I think. And the other problem is that a lot of questionnaires don't do a good job distinguishing either. We, at the same time, so we had them wear the accelerometer for 7 days over here. And over here, we asked them a questionnaire about the same 7 days, what kind of activity they did. And it was a recall, of the time you weren't sleeping, how much time was spent in moderate activity, how much time was spent in vigorous activity. And then here comes the problem. The rest of the time, the way this questionnaire, it assumes low activity, but what's going on is no activity in that in between time. And so they look like the controls, but they're not if you actually put accelerometer devices on them. And we just kind of modeled how this looked by age. And so these are the dialysis patients. This is just sort of modeling. And these are the controls. The units of our accelerometers at the time were literally arbitrary units. But now we use step counters and things like that. And so dialysis patients were lower than the controls at all the age groups, but the gap did tend to widen with age, which is an important issue since the median or the mean age of patients starting on dialysis is 65 now. So most of our patients are actually on that far end of the scale, where the differences are pretty large. So again, well, accelerometers are great, but it's really a bit labor intensive to try to do that. So we tried to see if we could develop some questionnaires that would do a better job of distinguishing people. And so in this USRDS special study, we had 1,640 participants who completed a questionnaire, and we used a pretty detailed, a longer instrument. It has 94 items, although it's pretty fast. It asks patients for each item to indicate whether they are still doing this activity, never stopped doing it, or never did it. And the items are sort of in order of metabolic demand, from just sort of sitting quietly to running 3 miles in 30 minutes, I think, or the sort of bookmark ends. And you come up with a maximum activity score, which is simply the highest thing that you say you're still doing. And then more importantly, an adjusted activity score, which is sort of more of an indicator of your general fitness level day to day, at least according to the developers of the questionnaire. And here's what we found here. These are men in the study by age group from less than 40 to 70 plus. And these are just box and whisker plots. And these are the healthy controls from the normative data from the questionnaires. And these were the patients that we surveyed. And what you can see is that in every age group, the 75th percentile for our dialysis patients was below the 25th percentile for the healthy controls. And it was worse for women. And I still don't entirely understand that. In general, women are less active than men, on average, but this is comparing women to women. And here, the 75th percentile was actually below the 10th percentile for all the groups for the women. So confirmed that they're very inactive, but this questionnaire has its issues in that it's actually quite good and it can discriminate pretty well. But it doesn't, it's hard to put in exactly how much time are they spending in activity. It doesn't ask that, how many kilocalories or any of that. It doesn't exactly get at it in that way. Nevertheless, it's a helpful questionnaire. And so then our next study was a study to try to look in more detail at what's going on in the muscle and trying to control for physical activity using that instrument and other things. So we enrolled 80 dialysis patients and we looked at muscle size, strength, physical functioning, fatigue, all of these other things. I'm not going to show you all the data about fatigue and such, but I'm going to show you some of the data about size, muscle size. So first question was, is there muscle atrophy in our dialysis patients? If I tell you that these patients are same age and sex, and if I tell you that the dialysis patient is A, do you think there's atrophy? Well, it's tough to say, but the answer is there's certainly, so these are MRI images. These are MRI images of the lower leg of the calf. And what we've done here is circled the anterior tibialis muscle because we were doing some specific strength testing and other testing of this particular muscle. We actually could, I think I took out the slide with the picture, but we actually could slide their whole leg into an MRI and have them do exercise while they were in there. So if you look at the outline of the compartments, they actually look pretty similar. But if you actually consider what the contractile area is, that's where you see the differences. So what we actually do is we take these images and we outline that region of interest, like I said, and then we partition it into what is fat and what is muscle, or non-contractile and non-contractile, most of the non-contractile being fat, but not all. And on the top is showing what a normal sort of profile looks like. And to figure out what our thresholds should be, I was working with people who do aging research, and they usually just outline an area that's about half subcutaneous fat and half healthy muscle. And they generate this intensity curve. And they sort of say, okay, here, this peak is muscle, and this peak is fat, and everything in between is sort of nerve bundles and other non-contractile tissue. But when we did that with our dialysis patients, it didn't even work. This peak is much wider, and this does not go down to this nice baseline here in between either. So what's happening is that there's fat just all throughout the muscle, much more so in our patients than in the controls. So we had to develop whole other methods for actually separating these two. But when we did that, we found what I've been saying already, which is over here on the left, that if you just look at the total area of those compartments, they don't look different at all, very similar. But the percentage that was contractile area was quite different. So there was definitely a lower amount of actual functional muscle tissue in our dialysis patients than in the control group. And we were interested in this question of whether or not they have normal strength within the muscle. So we looked at the relationship between their strength, and as I said, we were able to put a force plate and have them contracting that specific muscle, and then we had the cross-sectional area of that muscle. And so I'm just showing you here the one that is the relationship between the contractile part, so not the whole area, but the contractile part. And when we do that, we see these two slopes are slightly different. One is the dialysis patient and one is the controls, but statistically they're not different. And I should have maybe shown you the other one, but other people had used just whole compartment area. And there was this literature out there saying, well, even when you look at muscle size, they're still weaker than they should be. And I'm not convinced that that's actually true. I actually think that what's going on is that they have a lot of fat replacement of their muscle tissue. And I don't think we entirely know why that is yet, although sedentary behavior and older age are both associated with those things occurring. And so then we started thinking about what we could do about this and how we could make people think about this a little harder. And so first, we just wanted to know whether physical inactivity was associated with bad outcomes in our patients or not. So we looked at the association of physical activity with survival. And this curve is showing, based on that questionnaire that I showed you before, the developers of the questionnaire have taken that score and divided it into these fitness categories, average or above, fair, and low. And when we looked at people by that, we saw that there was definitely a worse survival among the people with the low fitness levels, the low activity. But based on what I told you before, you might not be surprised to hear that about 60% of the population was in this low already. So we said, well, what if we further divide the low into, very low, and extremely low by taking tertiles of the low. And so what we found was that even this is now just tertiles of the ones who are in the low to begin with. And so this gradient of this association between higher activity, better survival, or to put it the other way, lower activity, lower survival, persists even at these really low end of the scale. And when we look at this, it turns out that if you put these together as 5 groups, 1, 2, 3, 4, 5, those are almost quintiles because this low was already 60% of the whole group. And when you just look at this is adjusting for all sorts of other things, age, sex, race, albumin, et cetera, there's just a huge gradient between, a huge association between worse, low activity and low survival. And, of course, we know that this could just simply be that healthier people can be more active. I'm not saying necessarily that this is a causal association, but one thing I often say to people is show me another variable that has this kind of strong association. It's stronger than albumin and all the things we tend to look at. So it's something we maybe should be paying a little bit more attention to. And that's what I've been trying for a long time to get people to do. And we hit on this idea of frailty. We've been talking for a long time about poor physical functioning, et cetera, and I don't know, it felt like it wasn't resonating with people. And so we got the idea to think about frailty, and could we take this geriatric construct and apply it in our population? So many of you, I'm sure, are pretty familiar with the concept of frailty, but I'll just go through it anyway. There was a consensus conference in 2012 that came up with this definition here. And I like this definition, and I've highlighted different parts of it. These were the things they came to consensus about. They came to consensus that it's a medical syndrome. It's not one thing, that it has multiple causes and contributors, and that it's characterized by a decreased strength, endurance, and reduced physiologic function. And then specifically that it increases an individual's vulnerability for developing increased dependency and or death. So these things they agreed on. They actually didn't agree on some things. They specifically didn't agree on comorbidity and whether comorbidities should be part of the frailty construct or more of a contributor. But I'm a pretty big fan, and I don't know where my reference went, but I think it's this is from Fried's original group. Same references you'll see later. But this idea that frailty is that comorbidity, aging, inflammation, chronic disease, low physical activity, all can contribute to frailty, which can overlap with, but also can lead to, doesn't have to include disability. And so I may have taken out my slide. So there's, so people who have more comorbidities are definitely going to be more likely to be frail, but whether that constitutes frailty in and of itself is a bit of a question. Put this in just a little bit more detailed slide, kind of showing the same construct and showing kind of my bias about the sort of pathophysiology. But the idea is that you've got real oxidative stress, mitochondrial lesions, DNA damage, all these things that can come from aging or inflammatory diseases, contributing to inflammation, neuroendocrine dysregulation, and then eventually you can get anorexia, sarcopenia, some of these things. And then on the clinical side, what you could see is perhaps this kind of constellation of slowness, weakness, etc. And so this is what kind of really got us thinking, well, these things in here and these things over here are all happening in our kidney patients. They are inflamed. They have so many dysregulations of some of the hormones, IGF-1, all of these. And so might we apply this construct to patients with kidney disease? And might those patients even have frailty, even if they're not over 65? So this is the definition. This is the operationalization of this 5 sort of slowness, et cetera, that Linda Fried and colleagues at Hopkins and Jeremy Walston was on this slide, is also a key member of that group. They came up with this, and it's not important to look at all the details of this. This is just to sort of remind me, but 5 criteria: weight loss, which had to be unintentional weight loss; exhaustion, which was a couple of questions from a depression scale that you can see here; low physical activity, and they did divide this. They had a different cutoff for men and women because, as I said, women tend to be less active. Walking time, which is another way of thinking of gait speed, and grip strength. And so they came up with a criterion that any 3 or more of these would make someone frail. And 2 would be an intermediate frail, and less than that would be robust. So that was the schema. This was the slide I was looking for earlier. Apologies. They looked at what I was talking about before, the interrelationships between disability, frailty, and comorbidity. And the main thing just to recognize here is that they do overlap, but there are people who are frail who don't have comorbidities. There are people who have comorbidities and are not frail. And I think that's kind of an important distinction. And this is just to show that every outcome that they looked at, falls, mobility, et cetera, hospitalization, death, there was an association with this frailty score and mortality and all of these outcomes. And this is older community dwelling adults over 65. There is another scale that is certainly easier to do. I call this kind of the eyeball scale. And so a lot of people like this one. There are a million frailty instruments, by the way, I should say. I'm not going to go into that today. But this one, to my eye, is nice because it is at least an eyeball scale that's easily done. But it a little bit conflates disability and frailty more than perhaps the other one. But anyway, okay, this was the slide to tell me that we wanted to apply it. So in terms of seeing whether our patients were frail, we took some data that were already collected from a previous USRDS study, and and they had some questionnaire data about who was about people's functional status, et cetera, and we used that. We adapted that. We tried to adapt that to try to mimic this frailty construct. And so we used a definition. The Women's Health Initiative had done something pretty similar to this, where they had not initially measured physical performance and used questionnaires to try to to come up with criteria to use. So basically that's what we were doing here, was instead of measuring low physical activity, if they said they didn't do any physical activity, we counted them as low. And you can see here what we did. And so when we did that, here's what we found. We found that 2/3 of the patients were frail by this method. More women than men, as you do see in the general population. And the older people got, the more likely they were to be frail. None of that is surprising. And this is just a comparison with that cardiovascular health study where that definition was developed. Community dwelling elderly patients, or older patients, I should say, not elderly necessarily, over 65 and over. And so these were the rates or the percentages who are frail in their population. So overall, about 7%. And then these are by the age group. Now, these are not the same definitions, and that really is important. And we now know that this tends to come up with a higher number of people who are frail than this measured definition. And we know that because we've measured, and I'll show you that in a minute. But the important thing we wondered, though, was given that our patients have so much comorbidity and are already on dialysis and all of that, is frailty still important? Does it still make a difference? And the answer is that it does. In unadjusted analysis, it was really high. And even when we adjust for all sorts of other things, there was still almost a very similar hazard ratio actually for mortality as what they had seen in the CHS. So in other words, people who were frail had a mortality hazard ratio over a follow-up of about 2 years. That was a little over 2 after we adjusted for all these other things. So what it looks like is dialysis patients, even younger dialysis patients, can meet these frailty or this particular frailty definition, and that is associated with worse outcomes. So the next thing we did was to set out to really measure it exactly the way they did. And when we do that, instead of 2/3, we find about 1/3 were frail down here in the red here at the bottom. So it's about 1/3 who were frail. And this was a prospective study of about 732 patients, exactly 732 patients from 14 different facilities. So still not 2/3 if you measure it by physical performance, but remember, compared to 7% of over 65 community dwelling, this is 32% of people with a mean age of 57 years. So our patients are frail for sure. Since then, a couple of people have looked at the association, specifically Dalrymple et al. Have looked at this data here. I'll just go ahead and click it out here. This is using that same cohort, the CHS cohort now. So community dwelling elders over 65, but looking at them by their eGFR. So people whose eGFR, and this was by a cystatin C measure actually in this cohort, so that because creatinine-based measures might tend to underestimate because of loss of muscle mass in the calculation. So they used cystatin-based measures. And what they found was that as kidney function, patients with lower levels of kidney function had higher likelihood of being frail. And then I add here 2 bars, well, 1 bar with 2 different colors. This is again our data, 32%, and then Mara McAdams DeMarco and her group at Hopkins have also done a similar study where they mimicked the definition, and they came up with 41% in their particular cohort. So somewhere between 32 and 40, somewhere in that range, but quite a bit higher. And again, this was also patients that were not selected to be older than 65. So frailty is a big thing in this patient population. It is associated with mortality. I think I took out my slide where I compared the definitions because I thought that might be getting in the weeds a little bit for you guys. But suffice it to say that all of these definitions of frailty are associated with worse outcomes in our dialysis patient population. So let's turn to interventions to try to improve frailty. And well, this is not frailty, this is exercise capacity, but related to frailty. And I just picked out, there have actually been a lot of studies, a lot of exercise interventions in the dialysis population and in CKD and even a few in transplant. So this is just a review from a few years back, looking at CKD patients here, dialysis here, transplant here, and different exercise interventions. And you can see there are a lot of them, but basically over here, this side on the left favors exercise. So patients who were in these exercise interventions improved their exercise capacity. And we will come back to this in a minute. But for now, I want to just talk about, well, maybe I'll stay on this. So it has improved exercise capacity, and we've been doing this, but what we're not seeing is we're not seeing uptake of this. We're not seeing this happening. And I think there are a number of reasons for that. One is that most of these studies are very small. They've done many different, there's no standardized intervention. They've been different in terms of intensity, in terms of duration, in terms of aerobic exercise alone versus with strength training, et cetera. So we'll come back to that in a minute. But one question that's definitely come up a lot is whether our patients are too frail to exercise or to benefit from exercise. So I want to show you some data to address that a little bit. First of all, this study is ancient by our modern times now, but was really influential to me. Linda Fiataroni and her group published in JAMA in 1990 this study of high intensity strength training in nonagenarians. Okay, so these are elderly people, and these are elderly people who were living in a nursing home. So this is what they did. They took it was a small study, actually 10 patients, and these are their characteristics. So just to show you that the mean age, the range was 86 to 96. They had been 3.4 years in a nursing home on average, and they had a lot of comorbidity, et cetera. So this was not a healthy group of people. And what they did was they actually had them exercising in the bed, lifting weights with help in the bed. And what they saw over 8 weeks, and what they saw, this is just, from baseline to the follow-up, is pretty large increases in strength. So you can exercise if you bring weights to 90-year-olds and have them do that in their beds, you can increase their strength. So I'm not sure there's any such thing as too frail to be able to exercise, which led us to our study to try to see if we could increase muscle size and strength. So we had looked at the atrophy that we showed before. So then this study was sort of building on our earlier study of anabolic steroid, but really trying to get at not just what about if we look at exercise as an alternative intervention, and even then as the combination of the two. So it was a 2x2 factorial study of those two interventions. And we wanted to look at body weight, lean body mass, and then also to look at strength and performance and those kind of things. So this is just a little thing to show you sort of how we got our patient population. And this won't be meaningful to you too much right now, but one of the issues with some of the studies is that you'll see that they started with thousands and thousands of patients in order to, or 500 patients in order to enroll 30 patients. And we really tried hard to include as many patients as we could in this, and still missed quite a number, but managed to get down to 80 patients in the study. And we ended up with just about a 15% dropout rate, which is what we had actually powered for. And this is what we did. We had them actually, so these put on these ankle weights and do various leg lifting and knee extension and flexion in dialysis. And so it's a little hard to tell, but these weights have, maybe you've seen them, they have little pockets and you can add weights to them. So you can basically, we could increase the weight by increments of 1 pound at a time. And so ahead of time, we tested how strong they were, and then we started based on that, and then we increased them regularly when they could do 2 sets at the level where they were with good form, etc. So we looked at quadriceps muscle area, this time quadriceps rather than the lower legs, because that's more what we were exercising. And so these are the 4 groups here, placebo, nandrolone, decanoate, exercise that I showed you, and then the 2. And so what we saw was that, first of all, the placebo group had a tendency to decline over the time. This was a 12-week intervention. And all of the other groups increased the area, and there was no interaction between the 2 groups, meaning that effectively, as it kind of looks, this was an additive effect. So exercise worked, nandrolone worked, and the 2 together increased muscle, in an additive way, more or less. So what happened to their strength and function? Well, we found pretty big increases in strength. This is just pounds that they could lift in the exercise groups only, but not really so much in the nandrolone group. And that was pretty consistent across the different exercises. So training specific increases in strength, which is what you would expect to see. But again, definitely able to increase their strength in these muscles that we trained. In terms of physical functioning, so again, this is that same scale of the physical function scale that we talked about before, how limited people are and things that they could do. And again, the placebo group tended to decline. And I'm sure that I don't have to tell this group, but it's a real pet peeve of mine when there's not a control, because staying the same might be a benefit for some of these interventions. And you won't know that if you don't have a placebo group or a usual care group. But in any case, both of the exercise groups, but not the nandrolone alone group, reported better physical function at the end of the study compared to at the beginning. So this was encouraging to us. And this is just another panel from that same meta-analysis that I showed you before, but now looking at effects of exercise interventions on muscle strength, just to show that for dialysis, which is where a lot of the work has been done, across these studies, beneficial effects favoring exercise. Also, this is a fantastic study that I didn't have time to go over in CKD from quite a while ago, and even in transplant, there's a tendency to improve. So we can improve functioning by aerobic exercise and strength training. But as I was saying, it's just not standard of care. Partly they're so inactive. Oh, sorry. I'm going to do an interim summary here first, and then we'll move on. We've shown that they're really inactive, that activity is associated with size, muscle size, and physical performance, which I didn't show you so much, but it's true, and certainly with frailty. And it's associated with survival, even below the recommended levels. And the muscle wasting and weakness are really also associated with poor physical performance. And all of these things combine to lead to frailty. And they can increase their strength and functioning with exercise. But why aren't we doing it? Why aren't we doing it? Well, first of all, although I hope I've convinced you that almost no one is too frail to exercise if you can do it in the right way, it's that second part of what I just said. We didn't ask those 90-year-olds in the nursing home to go to a gym and do an aerobic. They didn't ask them to go to a gym and lift weights. They didn't ask them to go do aerobic training. They did weights in the bed with those patients. And so one of the problems is that these studies of exercise training in dialysis patients have tended to be small studies of very selected patients who can do that. But a lot of our patients cannot do that. And so I think that is a big problem. Plus, as I said before, the fact that there are many, many studies and they haven't all been the same. And even if we wanted to do it, we wouldn't really be able to tell you this is the regimen you should do because we don't have the data yet. I just put this up here. A lot of my talk has been older data. We're going to move into some newer data, but this just came out last month, I think. In AJKD, and I just wanted to show this because I think it proves my point. It was a wonderful study where they targeted patients over 55 with stage 3B and 4 CKD in Boston and in Maryland. And they screened 194, and they were able to randomize 99. The target was 120, but they did not get there despite actually lengthening their recruitment time. And then they had about 30 to 40% dropout rate, even though they had anticipated 20%. And so what they said was, despite an extension of the accrual period, the study did not meet its target, and dropout and loss to follow-up were greater than expected, often due to intercurrent medical events that precluded safe or feasible continuation of exercise training. I think this is absolutely critical because this is true for our patients with CKD and with dialysis. And in the interest of time, and I'm barely going to be on time as it is, I did take out the data that shows that these patients with stage 3B and 4 CKD are just about as low functioning as dialysis patients. So I don't want to leave you today with the idea that this is a dialysis issue. This is actually how your patients in kidney clinic or in your general medical clinic with kidney disease are too. So if that's the case, if they're down here on the activity curve, I'm not sure that vigorous aerobic exercise training, even if we scale it to what they can do, is the way to go. I really like this little cartoon that I found somewhere a while ago, just basically suggesting that the benefits of exercise are steepest in this low activity part of the range, when you move from not being active at all to doing something. And although in the old days they used to say you had to do 150 minutes a week, et cetera, the new thinking is something is better than nothing, and it can be broken up. And when it comes to the risks of activity, including cardiovascular, but especially musculoskeletal, those are relatively low at this low intensity and then go up as you increase the intensity. So why not focus down here on the low end? This would have the advantage of potentially being available and doable for more of our patients and possibly safer, although the exercise studies have not tended to show harm. I don't want to suggest that. So we tested, we did a pilot study to try to see if we could just get patients walking a little bit more. So we gave them pedometers, and we randomly assigned 30 patients to pedometers and 30 patients to usual care. And we had them wear the pedometers for a week. And then we gave them weekly goals. We talked to them every week about how they were doing. We gave them a report. We talked to them about progress, about barriers. In general, we asked them to increase 10% per week. And I can say more about that if you want. We kind of that it helped to kind of give them some individualized reports. They liked these graphs. So we would start, this is just an example, but we would, based on the start, we would project out if they met each weekly goal, where they would end up at the end. And then we would plot their weekly progress along that so they could see how they were doing. And, importantly, we also did not stop patients who were hospitalized. We simply met with them when they were able to start again, started a new baseline, and continued them on, which is something that is much harder to do in a more vigorous intervention. So it was a 3-month pedometer intervention. And then one thing that we wanted to know is if we do get them more active, will they stay more active? Because what we've seen, mostly we see nobody looking to see if this happens in dialysis interventions, but either just talking to investigators or in the few studies that have, we've tended to see that people revert right back to where they were. So we wanted to look at that. And anyway, so what we found was that the people assigned to the exercise, to the activity goals with the pedometer, which is the red group, did significantly increase their activity at 3 months compared to the controls. However, we stopped talking to them every week and giving them goals and just let them go on their own after that. And unfortunately, they did revert right back down to the baseline. So I think that not only do interventions to increase activity in patients with CKD or dialysis, or you name other chronic disease populations that you might take care of, not only do they need to have a plan to address intercurrent illnesses that occur during the intervention, but they also need to have a plan to address sustainability and how patients are going to potentially continue to do that after you stop talking to them every week. However, it can be done, at least according to this small pilot that we did. There was another group that did a study, a larger study in Italy with a sort of a different way of doing walking intervention, but they also were able to get their patients walking more. We did not see a statistically significant difference in symptoms or physical function, but we weren't powered for that. We did find in a post hoc, non-randomized sort of way that younger and more able patients did increase their activity more, and that those who did increase more did actually have more improvement in function and fatigue. So I've come to the conclusion that this might be as low tech as it may seem, although we can use Fitbits and we should, that we maybe need to step back from this idea of doing this fancy exercise training and just think about walking. I made this algorithm for a review I did a while back, and I just wanted to show it to you because this is my algorithm for initiating exercise intervention, and I really should say walking. And the point here is really just that, look at this, it's not a hard algorithm. It's a very simple algorithm. Can they exercise? If there's a contraindication, don't do it. If there isn't, and they can walk, then recommend that they walk. If they can't walk independently, then send them to a physical therapist to get them able if you can. So it's not a complicated algorithm. That's the other beauty of it. So I'm not going to recap the other conclusions, but just I think we need larger scale studies now to determine whether intervention does improve or prevent frailty and whether we can affect harder outcomes like hospitalization and mortality, but also can we affect these soft outcomes, these patient-reported outcomes, quality of life and fatigue that are so important to our patients that I didn't talk so much about today, but it really is important to our patients. And in the meantime, there's really not much downside to telling patients who can walk to walk more. And you can refer them to physical therapy and they will be happy and the physical therapists will be happy. And I think that with that, I will conclude. I have had so many, more than this even, but so many wonderful mentors and collaborators in all of this. And thank you for your attention today.
Thank you so much, Kirsten, for a wonderful talk. Any questions for Dr. Johansen? Yes, Sarah.
Yeah, thanks. That's a great question. So I'll recap it in case people online didn't hear. I'll try to So the question was, that we talked about the inflammation and the IL-6 and all of that as contributor to frailty, and then hospitalization occurs a lot, and to what extent is that causing or exacerbating some of this? And so I guess I'd say a couple of things. First of all, there really are some hospitalists and geriatricians starting to try to look at even whether just getting hospitalized patients up to walk around a little bit more can help prevent some of the declines that we see. But you absolutely do see declines in hospitalized patients. No doubt about that. And I was going to say something else about it, but I forgot what it was. So yes, I mean, that is an area of, I think, active investigation. It's tricky because patients are hospitalized for so many reasons, but I think it's a really important point.
One question regarding some of the studies on physical function. Have they looked at cognitive function as an endpoint?
No, we haven't. I think that would be a really interesting thing to do. In the general population, there is some literature to suggest that increasing exercise can either preserve cognitive function, preventing decline, more preservation than improvement, I think. And that would be really interesting. That group that where I showed that slide, I believe they were looking at cognitive function, and I don't remember what they saw. But I think they did look at cognitive function in that CKD group.
Yes.
Dr. Johansen, great talk. A question for you. You talked a little bit about gender and how that influences both the curve of decline. My question is about race. Given how CKD perpetuates differently in different races, have you thought or looked at, or is there data on both the decline over time and the response to exercise by race?
Yeah, that's a really good question. And I'm embarrassed to say we haven't done so much on that. In terms of looking at whether or not race is associated with frailty in CKD patients, that has been looked at. And that is a little, the results are a little bit mixed. In some studies, that Black patients are more likely to be frail than white patients, and in others, they're not. In our group, when we looked at it, when we used the Freed frailty criterion, we did not see a difference by race. What we haven't done is what you said about looking at whether response to interventions or trajectory over time differs by race, although I believe I took out the data on trajectory as well. We actually have looked, that study where we did look at frailty, we actually did it at baseline and at 12 months and at 24 months. And so we wanted to know what the trajectory was and whether it was reversible or not. And we found a slightly downward trajectory, as you would expect, but we did see people going both directions. And when we put race into the model, I do not think it was significant. But it's hard to power to see those differences. You need twice the sample size. So I don't think we have a definitive answer on that. It's an interesting question, important one.
Yes.
Mm-hmm. Yeah, that's a fit. So the question is, even though frailty is high, there were still a percentage that weren't, even in the older patients, et cetera, and have we looked at those? The answer is that we really haven't. I am fairly convinced, although we didn't do it, so this is just partly opinion, that physical activity is the key. We were talking last night about there's a well-known, if you're in the sort of exercise and kidney disease world, there's a well-known dialysis patient who ran marathons. But he's well known because there's one guy. So, that's really, really interesting. There's actually the Hopkins group Jeremy Walston and those guys, the geriatricians looking at frailty. They're doing some really interesting work trying to look at resiliency, which is sort of what you're getting at. The opposite of frailty would be resiliency. And so they're also trying to really look mechanistically. Could they really do, like glucose clamp studies and some of the physiologic things for people before and after stressors? So they're taking people that are going to undergo known stressors like medical procedures and trying to look at those who are more resilient and have better outcomes and those who are not, to try to get at the underlying physiology. So that's going to be really interesting, but we haven't.
Well, thanks everyone for coming to Medicine Run Rounds. Thanks so much, Dr.
Thank
Johansen,
you.
for a wonderful
Thank you
day.
for your
Thank you.
attention.